Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hey Sam, how's it going? Welcome back to Fuller Butz Podcast.
I'm excited to be back on the podcast, Dan. How's your week going?
It's a good start. Busy clinic day today. You're due to a pretty long day in the OR.
Yeah, started at the hospital, did a case, general plus local case, and then switched it up to some blocks, some Macs, some locals, and I'm sure all of our listeners know exactly what I'm talking about, right?
Yeah, that all makes a lot of sense.
Well, good thing.
Wait, big question though. Did you step on any spiders on the way to the hospital?
I didn't.
Bad omens?
I had positive vibes, green grass, no black birds flew past me, no fighting with my family members. So I felt like I can proceed with surgery very efficiently.
So what are we talking about today? What is all this?
If we haven't lost our listeners yet, we're going to fill you in. So we are talking about anesthesia, which is paramount for plastic surgery, whether you're doing a procedure in the office, which requires local or even topical, or whether you're doing a 6-hour mommy makeover. We are utilizing the full gamut of anesthesia, which is a frequently scary, anxiety-provoking field or topic, isn't it, Dan?
Yeah, I think, so many patients come in and it's like a rate limiting step for them. Like they're want to have the surgery, but they are scared of going under general anesthesia. A lot of times it's the first time they'll be doing that. So there's a lot of the unknowns that, they're not really prepared for. And I think the purpose of this is really to explain what we've been talking about the last several weeks of using these different types of anesthesia, what the options are, safety concerns, how to make sure we're doing it safely, and just running through the full kind of in some historical fun facts about it as well.
Yeah, so by the end of this podcast, you guys will be able to know without a doubt what a MAC and a block is and what general plus local means. And all of that is just meant to educate and inform and empower our listeners. So should we talk about the black omens and the...
Yeah, maybe that might add some context.
So during our heavy duty research on the Megan Fox episode, she discussed not only her plastic surgery procedures, but also the anesthesia that was provided during these procedures. And she mentioned that anesthesia was a big, scary thing for her. And so what were some of the things that she asked her anesthesiologists about prior to surgery?
She asked if there was any bad omens, like stepping on spiders or having fights with loved ones, anything that could kind of bring bad, juju into the OR and affect her experience.
Yeah, so I think that a running joke or something that's very common that my patients always ask me for the first start cases is like, did you get a good night's sleep? Are you feeling good today? Or, have you done this before? All these things that, kind of just break up the tension in the air. But I've never been asked if I stepped on a spider or if I had a fight with my wife the night before. Have you been asked any weird things prior to surgery like that?
No, how I often say, how are you feeling? Like, great. How'd you sleep last night? And that's a very common one, but nothing really beyond that.
Yeah. And so I usually tell patients just how safe anesthesia is during the consultations and even before surgery, as far as it just being a gateway to allowing you to have a safe, pain-free, process of surgery, at least during the procedure, and then hopefully to have a smooth transition in the post-recovery phase. But that was not always the case historically with surgeries. Dan, I remember I was telling you last week in preparation for this episode how I came across a really good audiobook or actual book called The Butchering Art by an author, last name Fitzharris, who just did a phenomenal job in retelling the basis of general surgery as well as the presence of anesthesia and its early development in the 1840s.
Yeah, it's pretty wild to think that they have been doing surgery since, back in the Egyptian era with just nothing. People just, really struggling through biting a bullet, stick, whatever it might be. And it wasn't until just the 1840s that, anesthesia came to be and allowed patients to be comfortable and do certain, bigger surgeries much safer and more comfortably. And it's, fast forward, 120, 40 years, a lot has changed, a lot more advances in the safety component of it to really allow us to do some pretty incredible stuff.
Yeah, and during our training, we learned about the early days of plastic surgery, where they would, as Dan mentioned, the Egyptian period, where they would, from a nose mutilation, they would actually take forehead skin and cut it off and rotate it down to reconstruct the nose. And we're like, oh yeah, we do that. It's called the forehead flap, but we didn't do that without anesthesia, and we certainly didn't do that without our current modern day techniques and suturing and stuff. So just thinking about how that was done 3,000 years ago and patients lived to tell a tale, and even 150 years ago, as Dan said, there were leg amputations and procedures done with minimal to no anesthesia. So we've come a long way, and it's only getting better and it's only getting safer. And so we thought that this would be a good break in the plastic surgery mold to talk about what we are needing and requiring and offering to our patients for our multitude of different procedures, which is anesthesia-based surgery.
Yeah, absolutely. So let's kind of break it down from the very least amount of anesthesia to then obviously more general anesthesia. Topical. What is topical anesthesia? When you think about that, where would you use that?
Yeah, topical is a great option for office procedures that don't require any additional anesthesia or surgery. So that typically is a gel-based or something that's liquid-based that's applied directly into the site. And so I'll do this for lip fillers. And so it's a combination of different anesthetics that works pretty quickly. I jokingly tell my patients, like, don't lick it, don't let it get in your mouth, because their tongue gets numb and then they're feeling like they're drooling. And so it works well. It doesn't, completely eliminate all pain, but it's something that works from the source. It's requiring the cells and the skin layer to absorb this drug, the medication, the anesthetic, and it's working locally on that. And so labiaplasties, fillers, what are some other areas where you would use topical? Anything else?
I often use it as like a starter before I use my injectable. Like, I don't do any lip fillers or, simply topical only. But our nurses use it all the time for lips or lasers to kind of help get a good base and make it a little bit more comfortable. But yeah, if I'm doing something in the office, I frequently put a little layer of that on first and then let that sit for a few minutes before we do the injection. Again, I was just trying to even make that needle point burn a lot more comfortable for them.
Yeah, and the anesthetic burn or the stinging is just based on its acidity, so it's pH. And so that's, we're injecting the medicine, and usually I say, it feels like a bee sting, and it'll go away very quickly. And that's getting into the local anesthetic that's actually injected below the skin into the surgical site with a very small hypodermic needle. Dan, what are some thoughts on that? Now we've talked about topicals. Now we're going into IVs or needle-based local anesthetic. What are good options for when you use local only?
Yeah, typically for smaller, office-based procedures, I wouldn't use this. I'll use it in combination. We'll talk about that later with general. But again, for labiaplasties, for little mole excisions, sometimes we'll do tiny or mini tummy tucks in the office under mostly local or tumescence. And we use a combination of either lidocaine, marcaine, and often bupivacaine. Not bupivacaine. Bicarb to take away some of that burn. But it's the process of injecting it to get those nerves numb, and we try to do it as slowly as possible to make it as comfortable. I'm sure you're using it a lot in your hand surgery. You mentioned a number of blocks and things as well, which is a little bit more focused, correct?
Yeah, for hand patients, local is a huge portion of my practice. And so a lot of patients just prefer to have local only, which means no IV, no anesthesia fee, no driver needed. They can drive themselves there and back. And so that's typically using, as Dan said, a couple different classes of anesthetics, either lidocaine or bupivacaine. And oftentimes it's coupled with epinephrine, which is a vasoconstrictor. And that really keeps the numbing medicine directly at the site that you injected, actually prolongs its effectiveness from working for 1.5 to 3 hours, all the way up to 6 to 8 hours or so. You can get really good effect from that local and epinephrine. But another word for epinephrine is adrenaline. Dan, do you know what a side effect or what I usually tell my patients, hey, you might start feeling jittery or something because you're getting epinephrine?
Yeah, it's like speed, and your heart starts racing. You kind of get a little jittery is a great way to describe it. So yeah, preparing patients for that. So they're like, why do I feel all of a sudden all jazzed up? To make them understand that it's just a normal reaction to that medication. And it doesn't just prolong the effect, especially in hand surgicalized local procedures. It also stops or constricts the blood vessels and makes the surgery much less bloody, and you can see everything a lot easier.
Yeah, so we do what's called Wallant surgery, or WALANT, which is wide awake, local anesthesia, no tourniquet. So we're really relying on the epinephrine to not only vasoconstrict for maximum numbing, but also to really make it a bloodless field so we can see what we're doing. And that's great. And then, as Dan said, bicarb is used to decrease the acidity, make it less of a burning sensation. And all of those are coupled into local numbing medicines that can be used on its own as a torn earlobe treatment that's just done in the office, for labiaplasty, for scar revision, all the way up to as an adjunct for more invasive anesthetics.
Yeah, so moving on to general anesthesia, there's different types of it, correct? You probably use it. No,
there's just one. No, I'm kidding. Yeah. So I was just kind of joking with at the start of the podcast. So I did a bunch of different cases. So I this morning using different variations of a general anesthetic, and that can be either done with an airway protection or without, and that's either endotracheal or LMA or laryngeal mask anesthetic and airway protection. And those are just variances that I kind of leave just for the experts with an anesthesiologist or anesthesia provider really determining what are those next best steps are. But those are just discussions that you'll be having at your pre-op appointments or at the pre-op holding area with your anesthesia provider.
Yeah, so there's really, there's also monitored anesthesia care where there's no airway protection, correct? So you have an IV in, they're giving you different medications to make you sleepy at certain times, less sleepy at other times, help with the pain. And that's where you can wake the patients up real quickly. But there's always someone there monitoring the airway or the anesthesia versus, when they control the airway with the mask, which basically is a kind of a large thing that goes in the back of the mouth versus a tube that goes down the throat. I think that's what's commonly associated with general anesthesia is that tube. And it is really an important and safety kind of focused feature to allow us to do, a lot of the longer surgeries and prone surgeries. We're doing back lipo or back skin excisions, to make sure you're really protecting that and preventing any potential aspirations.
So, while today I really wanted a patient to have a MAC anesthetic, which means no breathing tube, no airway protection, they're basically just snoozing or snoring. I essentially say that that's a sedation similar to a colonoscopy, a dental procedure where you have it through the IV. You'll likely have a nasal cannula or just some oxygen going into your nose and you're just snoozing and snoring. But I do want you to be light enough in case I need to wake you up to have you check and see if your finger's bending properly, if your motion is restored, and for other parameters. And so I would say a MAC procedure or a light sedation procedure is typically for shorter procedures that you feel you can well localize locally. Now, if I came into your office, Dan, and I said, hey, I want my 360 lipo. I want you to suck as much fat out of my back, my belly, my thighs, and I'm really nervous about anesthesia. Can you please just do it under a sedation or a MAC? What would you tell me?
I'd probably tell you no. I think those larger volume liposuctions are going to be actually safer under general anesthesia because otherwise if you're using too high of levels of the lidocaine or the markings and the tumescent agents, which we use to numb and decrease the blood loss, those can have cardiovascular issues at certain levels. So you can actually still use it with general anesthesia, but use a lower amount of it, and you're still comfortable. And again, then safety is the key thing.
Yeah, and I think I overheard an anesthesia provider talking about this and just the differences between general versus a sedation, and that a general is kind of like an airplane ride where there's a takeoff and there's a landing that you want to make sure things are secure, but otherwise the middle of the flight is usually pretty stable. There's not a lot of turbulence. Things are flowing well, whereas a MAC is a bit of an up and down where they're giving you medicines. You might be waking up. You're at different varying levels of awareness for that. Oftentimes, I would say 99.9% of the times patients don't remember the procedure, but they kind of are up. They kind of wake up and say, oh, wow, okay, then go back to sleep. And they need to be encouraged and be communicated with. And that's, the principle of monitored anesthesia care. There should be some monitoring involved. And so, that's just leads me to asking you, Dan, a couple of questions as far as, just adverse side effects or, questions that I'm asked during the consultations for plastic surgery and anesthesia. Is I have some patients who say, I don't want to remember anything, or will I be awake during my procedure? What do you tell those patients?
Yeah, I think that's a common fear. People watch TV shows or movies and people are waking up under surgery, and that really doesn't happen. I mean, there's very, very rare instances, but there's a lot of monitoring going on. You can really track based on heart rate and breathing levels, kind of how deep or not deep someone is, and there's someone there to adjust things and keep you at the right level, flying that plane, the right elevation. So I'm not aware of any patients that ever had any kind of awareness during the surgery. They often wake up and they don't really remember anything until they're in the recovery room. So kind of a period of time of amnesia between actually removing that tube and being more alert. And we often try to extubate, or not me, but the anesthesia provider, extubate on a deeper level to minimize coughing and other things that are often associated with the waking up period.
Yeah, and for me, it's the full spectrum of anesthesia, because for my tummy tucks, essentially we want to do a deep wake up to have the tube out, and they're just kind of breathing on their own for the last 30 minutes of the case. You're taking the tube out. It's a nice smooth passageway. And then I'll have a 17-year-old male who broke his hand punching and getting to a fight, where I really don't want them to wake up until the cast is fully on and set and things are good, and it needs to be very abrupt at the end. So there's multiple different levels of anesthesia, and I'm just very impressed that the anesthesia care in today's modern healthcare system is wonderful, regardless of whether it's a 9-month-old with an extra finger that I'm treating and ligating and reconstructing, or if it's a 90-year-old who I did today with significant arthritis, where we did a block or a regional anesthetic, which is very helpful, and that's something that we've talked about as far as the spectrum of anesthesia.
I think that you brought up a good point. We really rely on them. We trust the anesthesia providers, and it really is a part of our team. As much as and surgeons often joke about anesthesia, I'm sure they joke about us as well. We always blame anesthesia for little things, but in the end of the day, we're all working together to keep that patient safe and get them, landed and in the smooth runway afterwards. So I think that's an important thing.
Yeah, there's always these memes and jokes about anesthesia canceling cases and stuff, but they're canceling them for good reason, not because they don't like the person or the paperwork's not clear. It's because they have abnormal labs, or they have heart arrhythmias, or they've eaten something right before their breakfast or right before their surgery. And so these are indications to cancel a case, and the surgeon can be upset because it's outside of their control. But ultimately, anesthesia is keeping the patient safe, which is what everyone's overarching goal is.
This might be a good time to transition into what some of those preoperative things are the patients can do to optimize. You talked about not eating food. I just had to cancel a case a couple of weeks ago for someone who drank a protein shake 4 hours before surgery, which, the reason behind not having food in your stomach, this is the same reason why we have patients stop the skinny shot or semaglutide. We don't want to have any potential aspiration of gastric contents into the lungs and cause a pneumonia. So again, all this is safety based, but that's kind of one key thing. Normally say NPO for 8 hours for food. Again, if you're on the skinny shot, you need to stop, at least a week. I often say 2 weeks just to be extra safe. But what other things are you often telling patients kind of leading up to surgery to optimize or make sure that things go as smooth as possible?
Yeah, I mean, we always talk about smoking cessation at least 6 weeks before, just to decrease anesthetic risks, but even more so just poor wound healing, blood clots, just complications associated with surgery. There's supplements that can have adverse reactions and interactions with surgical medications. And then, I smiled when you were talking about the nothing to eat or drink 8 hours before, because oftentimes if I have a full hand surgery day where I have like 10 cases, some patients show up early, they show up late. And so like everyone, there's nothing to eat or drink after midnight. So if you're coming into my surgery, don't be like, oh, I'm at 2:00. I can have a full omelet at 8 a.m. because by the time it rolls around this afternoon, it's very likely that we would be getting to your case even before that time. So everyone's nothing to eat or drink after midnight. And then, Dr. Butz, I have really bad blood pressure. My blood pressure is always high. You told me not to eat or drink anything the day of surgery. Should I take my medications? Yeah,
typically you do want to take your blood pressure medications. I mean, you can get IV medications if you need to, but you don't want to show up for surgery and have a blood pressure through the roof in the pre-op area. We've had to cancel surgeries for that as well. So you want to, I send all my patients to get preoperative clearance. I used to kind of be more selective with it, but every once in a while someone would sneak through that didn't give us their full history and really should have gotten it. So now everyone gets one just to make sure we're not overlooking anything, see their doctor who knows them best, make sure that they can really optimize the medications. And we go through the common herbal supplements you want to stop. Some are good. I think there's a whole kind of newly developing field about preoperative nutritional optimization with extra protein, almost like carb loading for a marathon. And arnica, I think you use arnica for all your patients, right? Bromelain. Those are some medications that can help decrease bruising and swelling as well. So there's a lot of supplements that can help, but a lot that can thin the blood as well and increase risk of bruising and bleeding.
Yeah, for sure. It's a moving project of trying to figure out what's best for the patient and optimizing nutrition, and everything should be evidence-based before we start, having everybody take expensive supplements and so forth. But yeah, there's something to it. There's some patients who just fly and do great and have no issues with healing, and other patients who seem to struggle or slow down. And we're just trying to find that as surgeons, as doctors, as patients whose lives are in our hands. We're always trying to find that holy grail, of that opportunity to make sure that we minimize risks and complications as much as we can. But Dan, what would you say are like the most common side effects from anesthetic? Like what should patients expect, in the most commonest of situations? And then what are some ways that we try to proactively diminish that or decrease the chances of that?
Yeah, so common things patients often complain about is a sore throat. And that's something that's almost hard to prevent, especially if you're doing a 360 kind of liposuction case. Another one that's quite common is nausea and vomiting. So we throw we throw the kitchen sink at it. We use scopolamine patches. We put it on the night before. We give everyone Zofran. The anesthesia providers often give Zofran before, Decadron, a steroid, to help try to decrease all this. And certain anesthetic medications, I don't know all the details about that, but there's ones that are more likely to cause nausea, some that are not. So we try to just not even have the kind of not as good at stuff to use, and also limiting narcotics, right? So there's kind of a multimodal approach to pain control, try to decrease how many narcotics you get during surgery, after surgery, that can also decrease that nausea risk.
Yeah. So just to reiterate, it's, a multimodal approach to having patients have a safe and enjoyable, surgical experience. It sounds like in Milwaukee the night before by placing the scopolamine patch. We do it in pre-op in the holding area 30 minutes before surgery, and that decreases nausea. The patients get quote unquote the plastic surgery cocktail, which is Zofran for nausea, which is Reglan for calming the stomach, which is some steroids to help decrease postoperative nausea and vomiting associated with anesthetics. The medications that are being run during the procedure are typically the least likely agents to cause nausea and vomiting. And then even giving Tylenol or through the IV or orally can really serve as a pain reliever and anti-inflammatory. And then I would say right at the start of the case, right after the timeout, one of the first things we do for a general plastic surgery case is administer local anesthetic. And if we're injecting that right at the start of the case, allowing that to work, whether it's in the liposuction fluid, whether it's at the surgical site, patients aren't experiencing pain, and so the anesthesia team is not needing to administer pain meds during the procedure. And so they can really able to tolerate the procedure without a lot of narcotics on board. And that's also going to decrease not only post-op sickness, but also constipation and things that you can imagine would not be very pleasant right after a tummy tuck.
Yeah, constipation is another really common thing that we try to prepare patients for, try to get them on a regimen kind of leading into it and continuing through. Because once it sets up, it's not easy to undo. What's another common one for you? Or not for you, but for patients in general, after general anesthesia? Those are probably the big three.
I think overall, for me, it's fear. It's just the unknown. Like, I've never had anesthesia before of all different ages, walks of life. And that's just something, a big hurdle just to understand what that is. And it's just meant to protect your airways, to have everything from your circulatory system to your brain, your lungs to be working while we're undergoing this procedure. And then it's, I've had, so-and-so who is nauseous or throwing up. And it's what we just talked about as far as reducing that. There can be some other, I would say even less common, itching, rashes, some sort of irritations that are medically related, or, contact dermatitis from glue. And so you're trying to just troubleshooting, well, is this a medication allergy, or is this just something because you've had prep on your skin? And so those are, common things that we're troubleshooting after surgery, but certainly not reasons to not go through a life transformation or a journey to get you, the goals and the confidence that you want back, in my opinion.
Yeah. I think, for most patients, these little things are hiccups in the road, and typically we can try to do a lot to prevent them. But there can be some serious complications. That's why we take a lot of the preventative risk we do in terms of preoperative, evaluations, exams. What are some of the more serious things that can occur? I think it's important to be aware of those.
I mean, everything under the sun could possibly go wrong during surgery.
I think what I'm thinking of is a blood clot, right? I mean, that's one that, we do patient histories for, make sure you don't have family history, personal history. And if you do, we can give you blood thinning agents, kind of timed, after surgery. And, for even all comers, we have little compression devices in the calf, making sure the blood's moving to the legs. We get you pretty much walking out the door, 45 minutes after you're done with surgery, or maybe 45 to an hour and a half, depending on the length. That helps keep the blood moving, and we want you ambulating afterwards as well. So some people do compression stockings. Do you do compression stockings?
No, just SCDs and early ambulation.
Yeah, I was fine. Sorry to cut you off.
No, I was just, I wanted to talk about just fluids, eyes and nose, and that. So if this was a good segue, if you wanted to wrap up the SCDs.
Yeah, no, I was going to say compression stockings. I was worried they're really hard to get on and off, and that people are going to be struggling and then straining and, pulling too much. But SCDs and ambulation are the key thing.
Yeah, I agree. I think it's just less is more. If you're giving them all of these instructions and, they're just after surgery, how many are they actually going to follow? Everyone's going to prioritize. So try to keep it to the bare minimum of what I actually want and need, and that's evidence-based. But I think it's always great when I'm seeing the anesthesia provider looking at the urine catheter bag for some of the long cases that are over 4.5, 5 hours, where a Foley is used. They're checking the eyes and nose, or the ins and outs. So they're checking how much fluid I've placed for tumescent. They're testing and checking how much fluid they're giving through the IV, and they're making sure that it's balancing out so that somebody's not overloaded or volume up during the case, which makes them easier to extubate and easier to just recover if everything's balanced. And so they are checking more than just the airway. They're managing, quite a bit. And for, what Dan was talking about as far as the pre-op clearance, that's huge because, if there's an electrolyte abnormality, if there's some, family history of some severity of anesthetic reactions or things, it's better to know about that several weeks ahead of time, where that can be fixed. It can be planned for. Because, at our busy surgery center, which does cataracts, which does total joints, which does, knees and hips and spines and, hand, and then ultimately plastic surgery, there's cancellations. And I sit on the quality improvement board, and some of these are newfound hypertension, newfound, AFib, which is, very common, especially it seems in this post-COVID period where there's just a lot of secondary reactions to that. And so we're just seeing a higher prevalence of that. And so if you're just determining that ahead of time and you say, oh, I just need to be on a baby aspirin, I need to be regulated, you can still safely undergo your surgery rather than, being canceled the day of. And it's very frustrating for the patients who've made plans. They've had family arrangements, they've had social planning done for their big day, and then it needs to be pushed back so that they can get checked out. So as much as it's another step in the process of getting their surgery done, the pre-op clearance and the pre-op visits that you make your patients get, and I do as well, is meant for safety, and it's a good thing.
Yeah. Yeah, I think, the underlying thing is I think anesthesia is very safe. We often, commonly patients, like we talked about before, come in asking, like, am I going to die? And something I think we both probably tell patients is it's typically safer to be under anesthesia than driving yourself to the hospital, the surgery center, wherever it might be. The roads are a very dangerous thing, but we drive on them every day, so we take it for granted. So fortunately, anesthesia, thanks to all the advances that have happened over the last 150 years, is very safe. And we can take the right protocols and do this, to make sure you get as safe and comfortable as possible surgery and result.
Absolutely. Anesthesia is safe, and it needs to be evaluated just like a surgical patient needs to be evaluated. So, just as much as you may or may not be a great candidate for a tummy tuck or liposuction, you have to determine your candidacy for the right anesthetic. And so just to review, we've talked about topicals, just putting salves, gels with agents on there as a surface area, either to perform a filler, to pre-anesthetize or pre-numb before you actually inject with a needle. We talked about locals, using it through the IV for surgical sites, tumescent, or adding lidocaine or numbing medicine into the fluid for liposuction. And then we've talked about general anesthetic on the flip side, from tubes and airway to protection. And then in the middle, the MAC, or the monitored anesthesia care, or twilight sedation. And then there is one that we haven't talked about, which is the block, or the regional anesthesia. And that's something that I use heavily in hand surgery, in which the anesthesia providers place a block, which numbs the arm and makes it really great for surgery, in that we don't have to flood the space with a bunch of numbing medicine, so we're not working underwater. And it's wonderful because patients wake up with no pain, and it really has been shown and proven to decrease their pain medication requirements after surgery. So it's not unusual for me to do a pretty invasive thumb arthritis surgery and patients to have, to be on Tylenol, ibuprofen from day one, and to come back a week saying, yeah, I didn't have any pain after surgery. That's our goal. That's what it should be like. And, as I was prepping for the episode with Dan, I said, yeah, sometimes the blocks work 18 to 24 hours. And so we routinely tell our patients that, your arm may be numb for a day or so, and that's okay. It always wears off. I get the frantic patient who calls me like 12 hours later or the next day being like, I can't move my arm, it's dead. And I'm just like, you're welcome. That's a good thing. Like, you want to have that rather than pain, but it is scary. And it's to, not be able to have any sort of functionality or power to move your arm or to feel it. That is a side effect. Some patients really don't like that, but the converse of having pain after an invasive surgery is something that, we're willing to do, especially for sicker patients who are not able to tolerate a more in-depth anesthetic, a block works great. I told, Dan, I've used it in a pregnant patient who can't, should not have a general anesthetic just because there's 2 patients on the table. It's great as an adjunct to a twilight sedation where they can just be snoozing and the recovery is better. It decreases all of the associated risks that we've talked about. And it's just something great. And I know that you use quote unquote regionals or blocks as well for your tummy tucks, right?
Yeah, so tummy tuck, we use an ultrasound guided transverse abdominis plane block or tap block with the Exparil, which is similar medication to Marcaine or bupivacaine, but it's in this little special liposomal ball that slowly dissolves over 2 to 3 days. So that's really, I think, made tummy tucks a lot more tolerable than they used to be, and also not using drains, which we talked about quite a bit during our drainless tummy tuck episode. But that's a pretty major advance in abdominal and body contouring surgeries to be able to do that. I think you do that as well, but just inject it during the surgery. So very, similar locations, but it's different techniques. So pretty cool stuff. I think a pretty great overview. Is there anything we missed? Any other important things?
No, I just think that, even I had my tonsils out when I was 6, I think. And I remember having to breathe into this big bag. And I remember just how scary it was. And I would just say even for children, a lot of it has just changed. It's only gotten better. It's just more pleasant experience. I have my patients who come back, they rave and they want me to tell my anesthesia providers thank you and how great they were and how awesome they were in the pre-op area. They want to check on them in the recovery room and just making sure things are good. So from the full gamut of ages and medical history, we can undergo a surgery safely. It is safer than driving your vehicle, and probably for my kids going to school these days. There's some scary things going on in the world, and certainly you don't want to do surgery or perform anesthesia with reckless abandonment, but in the right hands with the right preoperative clearance, it's a home run, and it should be be seen with some anxiety. I think that's normal, but we're here to educate, inform, and at the end of the day, anesthesia is our teammate, and we are very happy to have them on board.
Absolutely. I think that kind of wraps it up. We went a little long as usual here. Do we know what we're talking about next week?
I thought we're going to have a Q&A or have our viewers.
Yeah, they're going to give a suggestion. That's right.
Yeah. So I think we'll leave it open to the viewers to pick a topic for us. So feel free to message us on Instagram, on Spotify, on any app that you're connected with and you're following us and subscribing. We appreciate the support, and we're here to educate within the realm of plastic surgery.
Yes. Good chatting with you again, and we'll be back soon.
Great job, Dan. See you later.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButtsMD. That's Butts with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.